So starting off with the obstetrics part 1. So in this obstetrics part 1, the first is the anemia and the pregnancy. In anemia and the pregnancy chapter, the first thing that is the most common anemia is going to be the most common indirect cause of maternal mortality. Total iron requirement that is equal to 1000 milligrams throughout the pregnancy, out of which 500 milligrams is required for RBC, 300 milligram for the fetus, and the next 200 milligram is excreted. Now the required daily intake, that is RDA, is about 4 to 6 milligrams per day, and remember about 10% of the iron is getting absorbed, so in that sense 40 to 60 milligrams per day should be consumed. Then according to the Anemia Mukta Bharat, the screening that is done is used by using the digital hemoglobinometer. IFA tablets, they're given from the start of the second trimester to 180 days postpartum. Deworming is done in pregnant women at second trimester by using 400 milligrams of albendazole tablet, that is standard tablet of albendazole. In case of non-pregnant women, obviously it is done biannually. Then delayed cord clamping and food fortification. So these are all the things that are included in the Anemia Mukta Bharat. Folic acid should be started at least 1 month prior to conception. So this is the ideal period. Now, iron folic acid, it should be taken 2 hours after the meals, and a minimum 2 hour gap it should be maintained with the calcium tablet. Similarly, it should not be consumed along with milk and tea. Now, anemia can be either physiological or pathological. The most common cause of anemia is obviously physiological. This happens because of hemodilution. So actually what happens as a maternal adaptation to the pregnancy, the plasma volume increases by 40 to 50%, while the RBC mass increases by only 20 to 30%, because of which there is anemia. The most common pathological cause of anemia is nutritional deficiency, and pathological anemia is where the hemoglobin levels are less than 11 grams per dl. Classification of pathological anemia is the mild, moderate, and severe. Mild is 10 to 11, then moderate is 7 to 10, and severe is less than 7. The clinical features for anemia are, so there are some antepartum and then are some postpartum features. Antepartum features will be placentobacally, that increases the risk of pregnancy-induced hypertension. Then there are increased chances of heart failure, preterm labor, and antepartum hemorrhage. While in postpartum, it will lead to postpartum hemorrhage, postpartum depression, subinvolution of the uterus, and poor wound healing. Hemoglobin monitoring is done in India 4 times, that is once every visit. However, in worldwide it is done twice, that is during the first ANC visit and then at 28 weeks. Then iron deficiency anemia is the most sensitive, or the best marker is going to be serum ferritin levels. When it goes less than 10, it is iron deficiency anemia. Most sensitive RBC index is the mean corpuscular hemoglobin concentration of less than 30. Then serum iron transferrin saturation less than 10, and total iron binding capacity of more than 400. So these are all the markers for iron deficiency anemia. However, the gold standard is the bone marrow biopsy, where the iron stain will be decreased. Then the next is the management of iron deficiency anemia. So for that, the oral iron therapy is given. Ferrous sulfate, which consists of 33% iron, and ferrous fumarate consists of 50% of the iron. 2 tablets are given per day till the hemoglobin reaches around 11 grams per day, and then maintenance dose of 1 tablet per day is given from start of second trimester up to 180 days postpartum. Now, what are the results that can be expected? So the retic count is the one that increases the first. So within 1 week, there's increase in the retic count. It becomes maximum by around 10 days. Hemoglobin in 1 month, there is more than 1 grams per dl rise should be present. If it is less than that, we should go for parenteral therapy. So the parenteral therapy, the approved formulations are first generation iron dextran intramuscular injection, second generation, third generation the IV. In second generation there is iron sucrose, and third generation there is ferric carboxymaltose. The best is ferric carboxymaltose, obviously. Now the requirement of iron is given by Guysson's formula. It is 2.4 into pre-pregnancy weight and multiplied by hemoglobin deficit, that is 11 minus the patient's hemoglobin, plus 500 milligram to replenish the stores. The infusion rate should be started at 15 to 20 drops per minute, and after the patient, if does not experience any nausea or vomiting, then you can go for 80 to 90 drops per minute. The maximum dose that can be given per day is 200 milligram, that is 2 vials can be given, and per week it should be 600 milligrams. So in a week only 3 times it should be given. Increased hemoglobin in this parenteral therapy is similar to that of the oral therapy. Contraindications for this are: first trimester should not go for parenteral iron therapy, similarly in hemochromatosis, or thalassemia major. So what do we go for thalassemia major? We go for blood transfusion. So blood transfusion is done in thalassemia major, congestive heart failure patients and hemorrhage patient. Here 1 pack cell volume should be given per day, which increases the hemoglobin by around 1 grams per day. Now a standard management protocol is given. Uh, According to standard management protocol, if there is a mild to moderate anemia, if it is less than 34 weeks, we go for oral therapy. If it is more than 34 weeks, then we go for parenteral therapy. If it's a case of severe anemia and the hemoglobin is less than 5, then whatever will be the duration of pregnancy, we go for blood transfusion. If the hemoglobin is 5 to 7 and if the timing is less than 34 weeks, we go for parenteral. If it is more than 34 weeks, we go for blood transfusion. Now, the next is the drugs that we can give in pregnancy. So the safe drugs are CAMP, that is cephalosporin, ampicillin, metronidazole, and penicillin. During the first trimester, what are the drugs that are contraindicated? Nitrofurantoin. Nitrofurantoin is the drug of choice for asymptomatic bacteriuria, which is common in diabetes. Right? Then warfarin. Warfarin leads to DeSalvo syndrome, wherein there are sinus defects. Then chondrodysplasia is seen, that is the nose deformity and stippled epiphysis. Along with that, cataract is seen. Then this warfarin, it can actually lead to fetal intracranial hemorrhage. So if the lady is taken warfarin, then you should not at a sudden stop the warfarin, but now you should go for C-section, because by vaginal delivery it can lead to fetal intracranial hemorrhage. If there are valves, mechanical valves, we go for anticoagulant along with aspirin. If there is bioprosthetic valves, we go for aspirins only. Antiepileptics, levetiracetam has the least teratogenic effect. Before conception, if a person is taking antiepileptics, then 400 micrograms per day of folic acid should be taken, and after conception about 1 milligram per day to 4 milligram per day folic acid should be taken. Next is the heart diseases in pregnancy. So in the heart diseases in pregnancy, before that we should know the maternal adaptation, wherein serious changes are seen. So what are the parameters that increase? So obviously increase in the cardiac output, heart rate, and femoral venous pressure, which increases the chances of varicose veins. Then there is a decrease in the peripheral vascular resistance due to progesterone, which is a smooth muscle relaxant, and there is a decrease in the BP. The diastolic blood pressure shows the maximum decrease around second trimester. What parameters remain constant? The JVP, then pulmonary capillary wedge pressure, and the left ventricular ejection fraction. The changes of heart failure. So changes of heart failure are, the chances of heart failure. The chances of heart failure, they're the maximum immediately after delivery, followed by second stage of labor, and followed by around 28 to 32 weeks. Now talking about the sounds. In the heart failure, the S1, S2 sound becomes prominent, along with a split can be seen, right? S3, S4 can be heard, gallop rhythm. Then the murmurs. So diastolic murmur, it is commonly heard in during pregnancy, which is physiological in nature. Ejection systolic murmur, less than grade 3 or continuous murmur, can also be heard. Most common heart disease in pregnancy is the rheumatic heart disease, and which is showing mitral stenosis. Now most common congenital valvular anomaly is going to be mitral valve prolapse. Then also atrial septal defect is the most common congenital heart disease. Most common congenital valve defect is MPP, and most common cyanotic heart disease is the tetralogy of Fallot. The most common cause of mortality due to heart disease is mitral stenosis, and most common maximum risk of mortality is due to Eisenmengerization. Now there are certain WHO class 4 conditions where pregnancy is contraindicated because there are risk of death during pregnancy. So these include the pulmonary hypertension, either primary or secondary, severe mitral stenosis or aortic stenosis, left ventricular ejection fraction less than 30%, NIHA class 3 or 4, or aortic root dilatation more than 4 cm, that is either associated with Marfan syndrome or coarctation of aorta. Then intrapartum management. Suppose if a lady does not come for follow-up and she continues with the pregnancy, then in the intrapartum management, the mode that is you have to continue with vaginal delivery, shorten the second stage of labor by using forceps greater than vacuum. The position of the lady should be in semi-recumbent position with left lateral tilt, and the IV fluid should be restricted, that is about 75 ml per hour it is given. Then C-section, the indications for C-section are severe aortic stenosis, severe aortic aneurysm, and aortic root dilatation more than 4 cm associated with Marfan and coarctation of aorta. Postpartum management, sometimes intractable PPH happens that can and we know that most common time for death or most common chances of heart failure they are during the immediately after delivery. So in that particular case, you have to give injection. Methyl ergometrine is contraindicated. Why it is contraindicated? Due to treatment contractions that increases the even workload on the heart. Now there are scores for acquired and congenital heart disease. For acquired heart disease there is a Karpik score, and for congenital heart disease there is going to be Zahara score. Then the peripartum cardiomyopathy. In peripartum cardiomyopathy, this is the main culprit is going to be prolactin. Here there is a high. We consider the time duration between 36 weeks to 5 months after a delivery as peripartum. As if heart failure develops between this is called as peripartum cardiomyopathy. Investigation of choice is echo, and in the echo, the left ventricular ejection fraction is found to be less. The risk factors are twin pregnancy, preeclampsia, and increased gestational age. Management is obviously you have to manage the heart failure, and along with that, the main culprit is prolactin, so you have to give bromocriptine. Then the thyroid disorders. In the thyroid disorders, there is going to be physiological things, that is, there is an increase in the size of thyroid. Then beta HCG, it is similar to the TSH, so it is going to stimulate the thyroid gland. So T3, T4 levels are going to increase, but at the same time, the estrogen is going to increase the thyroid binding globulin, and because of which the free D3, free T4 levels are remain to be normal. Thus, pregnancy is a euthyroid state. The RDA of iodine is about 250 micrograms per day. In the initial 12 weeks of pregnancy, the fetus is dependent on maternal thyroxine, and after 12 weeks, fetus has a self-production. Maternal hypothyroidism, the most common cause is Hashimoto's disease. In that particular case, you have to increase the dose of thyroxine that is initially given to the mother by about 40 to 50%. Maternal hyperthyroidism, the most common cause is Graves' disease. It can lead to IUGR in the baby, and here we know in that first trimester propyl thyroxine is given, in second trimester carbimazole methimazole is given. Thyroid storm, the drug of choice is propyl uracil, and symptomatic management is done by beta blocker, that is propranolol. So talking about the maternal adaptations, in the maternal adaptation, the first is going to be the cutaneous changes. In the cutaneous changes, we have the linea nigra and striae gravidarum, which are the stretch marks of the current pregnancy. Then the striae albicans, which are the grayish color in nature, which are suggestive of previous pregnancy. Then pregnancy mask, or that is also called as the cloisma gravidarum, which is seen in, which is a pigmentation on the cheeks. Palmar erythema, spider nevi are seen. Then what are the changes in the reproductive organs? In the uterus, it increases in weight about 1100 grams. Then uterine hypertrophy is greater than hyperplasia. Hyperplasia happens generally during the first initial weeks. Uterine placental flow increases to 500 to 750 ml per minute, and the uterus is explorotated. In the breast, the ductal growth is because of estrogen, while alveolar growth is mainly because of progesterone. In the cervix, there is a Jacquemus or Chadwick sign that is seen, that is bluish discoloration along the posterior wall. And then the length increases about 4 to 5 centimeters, the length of cervix. Ectropion is seen. Ectropion is seen, that is the endocervix. It proliferates and is completely physiological in nature. In the vagina, it becomes more acidic because of more bacteria, and the most common infection that can happen is the candidiasis. Then talking about the hormones, the prolactin is the estrogen normally inhibits the prolactin, but after delivery the estrogen falls suddenly, and because of which this fall in estrogen is actually the one that acts as the first stimulus for lactation. Otherwise, lactation or milk production does not happen. This prolactin levels, they are more during the second trimester as compared to lactation. The next is edema. There can be physiological edema, pathological edema. Physiological edema is below the level of knees, and it is pitting in nature and along the depending parts. While pathological edema is an circle, it is complete edema is seen. Talking about the blood parameters, the blood parameters that increase are the packed cell the plasma volume, then the red blood cells, WBCs, they rise about more than 15,000 during pregnancy. Hemoglobin rises, erythropoietin rises, CRP/ASR rises, right? Clotting factors also increase. What decreases are the hematocrit, blood viscosity decreases, RBC lifespan decrease, antithrombin 3 protein, C protein, S levels decrease, and albumin to globulin ratio remains 1:1. That is, albumin is going to decrease. Then in the renal parameters, the renal blood flow, the GFR is going to increase. Frequency of maturation increases during the first and the third trimester, and the bladder pressure increases. That increases the risk of stress urinary incontinence. Then hydroureter chances increases because of progesterone, that leads to decrease in ureteric colic. So there are increased chances of UTI, which is more common in the right side as compared to left side. Then what are the GI changes? Because of progesterone, it leads to increased chances of GERD, constipation, and increased risk of gallstones. In the respiratory system, some anatomical changes in the mnemonic 246. So 2, that is the transverse diameter of the chest, increases by 2 centimeter. By 4 centimeter, the diaphragm is pushed up, and the chest circumference increases by about 6 centimeters. Then the parameters that increase, they are the inspiratory capacity and the minute volume. Because minute volume increases, it increases the risk of respiratory alkalosis during pregnancy. Then the factors that decrease are the total lung capacity, residual volume, and the expiratory reserve volume. The factor that remains constant is the inspiratory reserve volume, respiratory rate, and the vital capacity. Similarly, the arteriovenous oxygen gradient, it decreases. That means oxygen consumption is increased. Calcium, the free calcium levels are normal, but however the total calcium or the bound calcium levels decrease. That means that the calcium uptake has increased. RDA in pregnancy for calcium is about 1000 milligrams per day, and for vitamin D it is 400 international units per day. A very important point over here is that it's a case of herpes simplex virus infection where there are ulcers that are seen, vesicular ulcers that are seen over the vulva or the vagina part. In that particular case, you have to go for C-section. Now talking about the next condition, that is diabetes in pregnancy. So pathophysiology for diabetes in pregnancy is a very important hormone that is responsible, that is human placental lactogen. Human chorionic gonadotropin as such does not have any role. Otherwise, estrogen, progesterone, inhibin, they play a very important role. The main pathology is increase in insulin resistance at about second trimester, around 24 to 28 weeks. The maternal glucose, it can pass the placenta and go into the fetus. Similarly, maternal thyroxine hormone can pass into the fetus. The gestational diabetes mellitus is about it takes about 6 weeks to come back to normal. Then there is a classification called as Priscilla White classification, where it is classified into type A and non-type A. So non-type A is going to be overt diabetes mellitus. Type A is gestational diabetes, where A1 is well controlled on diet and A2 is controlled on medication. Diagnosis, target scan or DEFA scan around 18 to 20 weeks. Overt diabetes mellitus is something where the HbA1c levels are more than 6.5% and the DIPSI test is positive. Then fetal echocardiography should be done about 22 to 24 weeks to rule out the heart defects, that is ventricular septal defects. The very important, the most common system that is affected is the cardiovascular system. The most common congenital malformation is the ventricular septal defect more than the neural tube defect. The most common cardiac malformation is the ventricular septal defect. More specific is going to be the transposition of the great arteries. And most common cardiac findings is HOCM. Then there is increased risk of pregnancy-induced hypertension, polyhydramnios, asymptomatic bacteriuria, and fetal macrosomia. Management, blood glucose monitoring should be done every 2 weeks in second trimester and every week in third trimester. Diagnosis, fetal monitoring should be done from 32 weeks, and that includes the non-stress test, biophysical score, growth scan, and umbilical artery Doppler. Low dose aspirin should be given from 12 weeks to 36 weeks, and it is the pneumonia is hypertensive mother scandal, it is Apla syndrome. Then chronic hypertension, multipetal pregnancy, chronic kidney disease, and diet, that is diabetes mellitus. The termination of pregnancy should be done in around more than or equal to 39 weeks and should be done by vaginal delivery. It is full term vaginal delivery is done. C-section is done only if the weight of the child it is more than or equal to 4.5 kg. There is a Barkow's hypothesis which says that the chronic diseases later in life due to the intrauterine conditions. Now talking about gestational diabetes mellitus in India, what is followed is the OGTT, that is oral glucose tolerance test, wherein 75 grams of glucose and 300 ml of water, 5 to 10 minutes. Here to see after 1 hour if the levels are more than 140, and after 2 hours we'll look for more than 120. If it is more than 200, then that is overt diabetes mellitus. If vomiting happens within 30 minutes, you have to repeat it the next day, and if it happens after 30 minutes, then you have to continue it. Then insulin, there's a human premix insulin 30 to 70, 30 short acting, 70 is intermediate acting. 1 vial consists of 40 international units. The storage is 4 to 8 degrees Celsius, and the syringe can be reused 14 times. 30 minutes before the breakfast, we take the insulin, then look for postprandial reading. If the postprandial reading is less than 120, it's okay. But 120 to 160, add 4 international at 4 units. 160 to 200, 6 units, and then more than 200, then 8 units. Then look for fasting blood sugar. If it is more than 95, then add 2 units pre-dinner. So in this way you have to continue. And termination of pregnancy, as I said, if it's a well-controlled condition, then you have to go for a full-term vaginal delivery. Okay, and if it's not a well-controlled condition, then wait till 37 weeks. You should not continue it further than 37 weeks because there is always a risk of stillbirth. Maternal complications because of diabetes are maternal hyperglycemia, increased chances of infections, asymptomatic bacterial candidiasis, polyhydramnios, oligohydramnios due to diabetic vasculopathy, placentomegaly, hypoglycemia. Then fetal complications, they are given by this Peterson's hypothesis, where there is increased fetal insulin that will lead to increased fat deposition around the shoulder. Macrosomia increases the chances of shoulder dystocia, and because of macrosomia there is increased oxygen consumption, increased oxygen stress that can lead to hypoxia and increased risk of stillbirth. Neonatal complications are hypoglycemia that is associated with hypocalcemia, magnesemia and hypokalemia as well. Along with that, RDS, NEC and hypoxia that leads to polycythemia. So very important to remember, in neonates anemia is not a complication of maternal diabetes. Lung maturity, it is done by amniocentesis during the third trimester. Here the most common method that is done is lecithin. Sphingomyelin ratio, it is more than or equal to 2, it is normal. The best, however, is the phosphatidylglycerol and lamellar body count type 2 pneumocytes. If they are more than 50,000, then that's normal. 9-blue sulfate test, if it comes out to be blue in color, that is immature. If it comes out to be orange in color, that is going to be mature. Here we use the skin cells because they have the same time as that of the lung cells for maturation. Then the shake test or the bubble test can be used. Then shoulder dystocia. So in shoulder dystocia there is turtle sign that is positive. For 1 minute it is no shoulder outing after the head comes out. The maneuver that is done over here is the helper. So mnemonic is given by helper. So H stands for call for help, E stands for liberal episiotomy. Then the next is the legs maneuver that is called as the McRoberts maneuver, wherein it increases the space, pelvic space, and it's by straightening the sacrum. There are increased chances of injury to the lateral cutaneous nerve of thigh, leading to neuralgia paraesthetica. And the P stands for pressure, where you have to apply the suprapubic pressure and not fundal pressure. E stands for intermaneuver. In the intermaneuver, both the shoulders are taken out by Wood's corkscrew maneuver, or if a single shoulder is taken out by Rubin's maneuver. Then R stands for remove the posterior arm by Jacquemus maneuver, and another R is roll on all the 4 limbs by Gaskin's maneuver. And lastly is the Zavanelli's maneuver, which is the last resort. You have to push the head back and go for C-section. Most common complication is going to be the Erb's palsy, wherein in the fetus, while in the maternal side, the most common complication is the PPH, that is postpartum hemorrhage. It's a case of dead fetus that will do clidotomy or symphysiotomy, and future pregnancy, there is always a risk of shoulder dystocia. Next topic is hypertension in the pregnancy. The first is definition. So definition, pregnancy-induced hypertension is where the blood pressure is more than 140 by 90 on 2 different occasions at least 4 hours apart in sitting or semi-recumbent position. You never have to measure the blood pressure in a supine position because it can lead to supine vena cava syndrome. Then pregnancy-induced hypertension, it is seen in more than 20 weeks of pregnancy. It results within 12 weeks of delivery. Diabetes, it results within 6 weeks of delivery. Here it requires 12 weeks. In less than 20 weeks also, pregnancy-induced hypertension can happen if it's a case of multivital pregnancy or vesicular bone. Smoking is protective. Aspirin, low-dose aspirin is given in all hypertensive mothers can die pneumonic. Now there are certain predictors. SFLT levels, serum integrin levels increases, VEGF levels decreases. Best predictor is going to be serum FMS like tyrosine kinase. First organ involved in PIH is maternal kidney. Then there is something called rollover test, wherein the BP increases by 20. And then there's isometric exercise test, that is hand grip test, where the BP increases by 15 mmHg. Then uterine artery Doppler, where the persistence of diastolic notch is seen after 20 weeks. Pulsatility index increases, resistance index increases. Fetal monitoring, it should be done at around 32 weeks. Uterine artery Doppler, if the findings are such that the SYD, systolic by diastolic ratio, is more than 3, then you have to terminate by 37 weeks. Then by 34 weeks, if there is absent end-diastolic flow, reversal of end-diastolic flow by 32 weeks. So this is very, very important. Management of chronic hypertension can be alpha-methyl-dopa-labetalol or nifedipine. Pulmonary edema, In those cases, loop diuretics can be given that leads to sudden dyspnea, SpO2 fall less than 90, or bilateral basal crepitations can be heard. Now talking about the preeclampsia, so preeclampsia is nothing but hypertension with new onset proteinuria. So proteinuria is about more than 300 milligrams in 24 hours. Serum protein creatinine ratio is more than 0.2, and urine dipstick is more than or equal to 1 plus. And along with that, increase in ALP. Now preeclampsia is divided into two types: mild preeclampsia, severe preeclampsia, or preeclampsia with no severe features, and preeclampsia with severe features. So mild preeclampsia is where the BP is less than 160 by 110. In severe preeclampsia, the BP is more than 160 by 110. Along with the signs of end organ damage are seen. That is platelet count less than 1 lakh. Then the liver enzymes, STOD, STBT ratio is more than twice the normal. Serum creatinine is more than 1.1 grams per DL, and pulmonary edema or visual symptoms can be present. What are the signs of impending eclampsia? In impending eclampsia, there is going to be subcapsular hematoma in the liver leading to epigastric pain. Apart from that, severe headache is present and visual disturbances. Reversible blindness can be present. However, in case of central retinal artery occlusion or retinal detachment, it leads to complete blindness because of Keith-Wagner classification. Now, the next is management. So, management for mild preeclampsia, it is going to be we have to wait till only 37 weeks, not a full term delivery. Okay. And antihypertensives are given. In case of severe preeclampsia, you have to administer magnesium sulfate, antihypertensives, and corticosteroids. If it's a case of emergency, then you have to give only one course of steroids. If it's non-emergency situation, then complete course of steroids is given. Eclampsia, it presents with the general tonic-clonic seizures. There are three types: antepartum, intrapartum, postpartum. Postpartum within 48 hours. Antepartum is the most common and having the worst prognosis as well. Investigation choice, we can go for MRI where posterior reversible encephalopathy is seen. Anesthesia is general, and management is by giving magnesium sulfate. Magnesium sulfate is used to treat diseases, prevent diseases. Also, it has a tocolytic action and neuroprotection. Magnesium sulfate reacts on the NMDA receptors. It has very narrow therapeutic range, and most common cause of death is intracerebral hemorrhage. Pressure regime is important, wherein loading dose and maintenance dose are present. So loading dose IM and IV. So IV, it is 4 milligram of 20% solution, and IM, it is 10 milligrams 50% solution, 5 milligram in each bottle. Then maintenance dose consists of intramuscular 5 milligrams in alternate bottle every 4 hours till 24 hours post delivery or post seizures, whichever comes later. Then you have to check for the deep tender reflexes, respiratory rate, and urine output. So the deep tender reflexes should be present, respiratory rate should be more than or equal to 12 per minute, and urine output should be more than 100 ml in 4 hours. Then there is another regime that is called as Sibai or Zuspan regime, where the IV loading dose is 4 to 6 gram and 1 to 2 grams per hour is the maintenance dose. Apart from that, there is a Dhaka regime and all different regimes are present. The magnesium toxicity. Magnesium toxicity, the first sign is going to be the loss of deep tender reflexes. It is seen at around 9 to 10 milliequivalents per liter. Then about 12 milliequivalents per liter, there is respiratory depression, 15 cardiac arrhythmia, and 24 or 25 there is cardiac arrest. Treatment for magnesium toxicity is calcium gluconate 10 ml IV. Then preeclampsia has severe features, but if it's a stable condition, then you don't have to do immediate termination of pregnancy, but you have to administer magnesium sulfate, antihypertensives, and manage the patient. In severe preeclampsia, and if the vitals are unstable, or it's a case of eclampsia or HELP syndrome, in that particular case, you have to go for immediate termination of pregnancy as a definitive management, but before that, you have to administer magnesium sulfate to stabilize the patient. Now, what is the pathophysiology actually? So pathophysiology, as we know, that there are spiral arteries, and the spiral arteries, they are having a high resistance, because of which the blood flow is initially less. The vascular remodeling happens. It begins at around 12 weeks in the decidua, and by 16 to 20 weeks in the myometrium, where there is unspiraling of the arteries that decreases the resistance and increases the uteroplacental circulation. This theory is called as a trophoblastic invasion. Vascular remodeling theory, it is done by extravillous endovascular trophoblasts. Then the release of these predators which increase are the SFLT, endoclin, TNF alpha. The predators that decrease are the vasodilators, that is the VEGF, then placental growth factor, PGI2 levels. Cerebral vascular pathology is because of capillary leak. It leads to cerebral edema that will lead to headache, seizures, eclampsia. Cerebral hypoperfusion leads to headache, and visual disturbances are seen, which are the feature of impending preeclampsia or signs of impending eclampsia. And this is going to be a short table which is going to be summarizing the timing of delivery. If it's a case of gestational hypertension which is well controlled, then 38-39 weeks, that is full-term delivery. If it's a case of mild preeclampsia, they wait till 37 weeks. If it's a case of severe preeclampsia, around 34 weeks. And if it's a case of eclampsia HELLP syndrome, then magnesium sulfate for stabilizing the patient and immediate DOP is done. Then the liver disorders. So liver disorders, the most common that is asked is the HELLP syndrome. So HELLP syndrome, that H stands for the hemolysis, EL stands for the elevated liver enzymes, and LP stands for the low platelets. It is common in multigravida females, pregnancy-induced hypertension, that is in preemies. The clinical features are the right upper quadrant pain along with jaundice. The criteria that is used is the Tennessee criteria. So Tennessee criteria you can remember by this mnemonic HELP itself. So low platelet counts, that is less than 1 lakh, elevated liver enzymes, that is more than or equal to twice normal, and H, that is hemolysis. So in the hemolysis on the peripheral smell examination you will find the Burr cells or the schistocytes. Serum bilirubin levels will be more than 1.2 milligrams per dl, and the LDH levels will be more than 500, and decreased serum haptoglobin. Normal APTT, PT or fibrin degradation products. Management is magnesium sulfate plus first dose of steroid is given, and termination of pregnancy should be done immediately at any pregnancy age. Classification that is used is Mississippi classification. Next is the AFLP, that is acute fatty liver of pregnancy. Acute fatty liver of pregnancy, it happens because of the absence of enzyme that is called as LCHAD. So homozygous LCHAD deficiency in case of fetus and heterogeneous LCHAD deficiency in case of mothers, because of which all the long chain fatty acid, it goes into the mother's liver and gets accumulated. Due to the accumulation in the liver, there is a liver failure which increases the PT, APTT, DIC profile, FDP, right, increases the chances of hepatic NCAF. Apart from that, renal failure happens, and the most striking feature that is generally a buzzword in the MCQs, that is hypoglycemia is seen, or pancreatitis is associated with it. Clinical features are simply nausea, vomiting is seen. Management, you have to stabilize the patient and immediate termination of pregnancy is done. It normalizes around 1 week post delivery in mothers. Intrahepatic cholestasis of pregnancy. In intrahepatic cholestasis of pregnancy, there is a accumulation of bile acids. Because of bile acid accumulation, the mother will complain of pruritus over the palms and soles region at night. Prematurity, then there are decreased vitamin K that leads to increased chances of antepartum hemorrhage, and it irritates the uterus. So in mothers, it can actually lead to preterm labor. In fetus, this bile acid is present in the amniotic fluid, which the fetus will swallow, right? That can lead to meconium aspiration syndrome. Similarly, it can reach the heart, and that can lead to sudden fetal demise due to cardiac arrest. So this is a very important buzzword that is given. There is a sudden fetal demise due to cardiac arrest can happen. Diagnosis: serum bile acid more than 10 micrograms per liter, and then increased bilirubin and all. Management: you have to do ursodeoxycholic acid in the mother, vitamin K, and the termination of pregnancy, that is induction of labor, it is done at around 37 weeks. So only intrahepatic cholestasis of pregnancy is the only liver condition where you don't have to do an immediate top. The next condition is the Rh negative pregnancy. So in the Rh negative pregnancy, starting with the Rh negative pregnancy, the Rh antigen is located on the short arm of the first chromosome, that is 1p. Then the first pregnancy is considered is safe, and the complications are seen in subsequent pregnancy. What are the fetal complications? That will lead to anemia, which has increased chances of hydrops fetalis and heart failure. Then jaundice, then hepatosplenomegaly and bone marrow hyperplasia, which is characteristic features of erythroplastosis fetalis, and placentomegaly, that is leads to pregnancy-induced hypertension risk in mother. For anemia, the screening test that is done is CTG, that is non-stress test. There is a sine wave pattern that is seen, and Doppler of the middle cerebral artery is done, which is the best non-invasive screening method, wherein the peak systolic velocity is more than or equal to 1.5 MOM. Then the ICT, that is indirect Coombs test, that is done to find out whether the mother is sensitized or not. It is done in the first ANC visit and at around 28 weeks. So if it is, if the ICT is negative, that is the mother is not sensitized, and you have to give anti-D, antepartum prophylaxis. It is given at around 28 weeks, and it is about 300 microgram. 300 microgram, it is for 30 ml of fetal maternal hemorrhage. So generally we predict that 30 ml fetal maternal hemorrhage will take place, and early cord clamping should be done. Delayed cord clamping is done when already it is sensitized, so तसंही काय फायदा नसतो. Then direct home test of the fetal blood is also negative. Anti-D postpartum prophylaxis is done for more than 72 within 72 hours to protect the next pregnancy. Now, even if the mother has taken the anti-D at around say 28 weeks, but she loses her fetus during some 3 days. Within 3 days only she loses her fetus, but then too she has to take the anti-D prophylaxis within 32 days again. Now, if in the question is specifically mentioned that the fetal-maternal hemorrhage is more, for example 45 ml, in that particular case you have to increase the dose of anti-D, that is around 450 microgram is given. Now if the ICT is positive, then you have to look for the antibody titer. If the titer is less than 1:16, then you have to repeat the titer every 4 weeks, and expected delivery is done at around 37 weeks. If the titer is very high, more than 1:16, in that particular case you have to look for anemia. Look for anemia by the PSV, that is peak systolic velocity, on MCA Doppler. If it is less than 1.5 mom, you have to repeat this every 2 weeks, and her delivery is done at around 37 weeks. If it is more than 1.45 mom, then chordocentesis is done. The only indication for chordocentesis is Rh negative pregnancy. Now, it's a quantitative test. If the hemoglobin is within 2 standard deviations, similarly, if the hematocrit is more than 30%, in that particular case, you have to repeat it. Hemoglobin monitoring and fetal monitoring. It's a case of mild anemia, again, delivery at 37 weeks. If the hemoglobin is less than 2 standard deviation, if the hematocrit is less than 30%, then that is a case of severe anemia. Here the delivery is done. It depends. If the pregnancy age is more than 34 weeks, then straight away go for delivery. If it is less than 34 weeks, corticosteroids are given and intrauterine blood transfusion is done. Okay. So the only thing is to remember in Rh negative pregnancy is, if it's a case of ICD negative, if it's a case of ICD positive with low antibody titers, or no anemia or mild anemia, in all these cases you have to do a termination of pregnancy at 37 weeks. But if it's a case of severe anemia, then that particular case, if it's more than 34 weeks, delivery करून टाकायची. Less than 34 weeks, intrauterine blood transfusion. Then fetal-maternal hemorrhage, it can happen because of abdominal trauma, twins, instrumental delivery, intrauterine death, and manual removal of placenta. 1 ml of fetal blood साठी 10 microgram of anti-D is required. The screening test is a Rosette test, which is a qualitative test, and quantitative test is the Klehor-Bethkes test. Indications for anti-D are for 50 micrograms to 200 microgram intramuscular injection. It is given after abortion, after ectopic, after molar. Then due to chorionic villi sampling or amniocentesis. Amniocentesis, we can also look for anemia with delta UD 450 analysis, where serum bilirubin levels are checked. Then after performing any maneuvers like external cephalic version or internal podalic version, and antepartum hemorrhage. The risk of immunization is due to Kale, Kid, Duffy antigen as well, and most common is Kale antigen. The most common non-D antigen is the E antigen, and most severe non-D antigen is the C antigen. Then mirror syndrome or Valentine syndrome. Mirror syndrome or Valentine syndrome is basically की fetusमध्ये hydrops असतं आणि मदरमध्ये पण polyhydramnios, म्हणजे दोघंही टमटमलेले दिसतात. So in the fetus, it's a hydrops, that is the first sign that is seen is the scalp subcutaneous edema, that is called as the Buddha sign, even hydrops. And the mother that polyhydramnios is seen, which is also seen in twin transfusion syndrome, cystic hygroma, and Rh negative. Anti-D immunoglobulin that is given antenatal at 28 weeks. It lasts for 12 weeks, that is till 40 weeks, and then post-delivery ideally should be taken within 72 hours. Hemodynamic disease of the hemolytic disease of the newborn can happen because of ABO as well as Rh incompatibility. ABO incompatibility, it happens within 24 hours, and Rh incompatibility after 24 hours. Within 24 hours, there is no anemia and there is less severe hydrops that is seen. So first pregnancy, Rh positive baby, anti-D immunoglobulin. Next pregnancy at 28 weeks, take the same dose, that is 300 micrograms. So no changes done. So this is all about Rh negative pregnancy as well. So these are the medical and surgical complications during the pregnancy. The next is obstetric complications. So the next in the obstetric complications is going to be the abortion. Abortion, it is characterized by a pregnancy loss at less than 20 weeks. A pregnancy loss at more than 20 weeks is considered to be intrauterine death. The WHO criteria is the weight of the fetus should be less than 500 gram or about 22 weeks. Isolated abortion. Isolated abortion is the abortion that happens in between the two pregnancies, or it is not a consecutive abortion. The most common cause for isolated abortion will be the chromosomal anomaly in the first and the second trimester, out of which the chromosomal anomaly, the aneuploidy, followed by trisomy, followed by 45, so that is monosomy. The most common trisomy that leads to intrauterine death or the pregnancy loss or the abortion is going to be trisomy 16. Infection, congenital syphilis, it follows the Kassovitz law, that is the prognosis is directly proportional to the number of pregnancies, and it has increased chances of stillbirth. HIV is neither abortogenic nor teratogenic in nature. Recurrent infections where there are more than or equal to 2 losses at less than 20 weeks. So previously it was more than or equal to 3 losses, but now it has been changed to more than or equal to 2 losses at less than 20 weeks. The most common group of causes is going to be endocrine cause, followed by the uterine cause. In the endocrine cause, the most common is hypothyroidism, got from the diabetes, PCOS, or increased prolactin can be a cause. In uterine causes, it can be congenital or acquired. In congenital, it is a septate uterus greater than bicornuate uterus, and it leads to abortion in the second trimester as compared to first trimester. In acquired, the most common cause for painless acquired abortion, that is in the second trimester, is the cervical incompetence. Cervical incompetence is where the cervical length is found to be less than or equal to 2.5 centimeter on the transvaginal ultrasound. We manage this condition by either cervical cerclage or giving progesterone. So progesterone is used to prevent a preterm labor. It is started by around 12 to 24 weeks and you have to stop it by around 36 weeks. So similarly, cervical cerclage should be put at earliest at about 12 weeks, and it should be removed at around 36-37 weeks. If it's a pregnancy of less than 24 weeks and if it shows a cervical dilatation, then that's a case of emergency cerclage. It is bone cerclage is to be placed. The most common cerclage that is placed is transabdominal. Here we have two types, that is McDonald and Shirodko, that we'll see later. Lash and lash was the first transvaginal cerclage that was described. Cervical incompetence, how it is diagnosed? It is diagnosed with the passage of number 8 Higgins catheter or passage of number 16 Foley catheter, which is filled with 1 ml of water. Cervical cerclage indications will be more than or equal to 2 painless second trimester abortions, 1 painless second trimester abortion with a transvaginal ultrasound of length less than 2.5 centimeter, history of preterm labor with cervical length less than 2.5 centimeter, or it's a case of pregnancy less than 24 weeks which shows cervical dilatation as well. Then the recurrent abortion. The most common cause of recurrent abortion is going to be the APLA syndrome. This APLA syndrome is going to be a single individual most common cause. The most common chromosomal anomaly that leads to recurrent abortion is the balance translocation. Trisomy 16 is the one that leads to isolated abortion. Then APLA syndrome. APLA syndrome, it's a syndrome where a lot of thrombosis is seen. Here there are 3 important antibodies that are seen, that is lupus anticoagulant antibody, then anti-cardiolipin, and anti-beta-2 lipoprotein antibody is seen. And this leads to mostly first trimester abortion. Modified Sapporo-Sydney's criteria is present. According to the modified Sapporo's criteria, there should be one clinical and one lab parameter should be satisfied. So one clinical parameter should be either there is a history of arterial or venous thrombosis, or there is a history of more than or equal to 3 first trimester abortions less than 10 weeks, or history of more than or equal to 1 fetal loss for more than 10 weeks, or history of more than or equal to 1 preterm labor less than 34 weeks. Lab criteria is lupus anticoagulant antibody, which is either IgG or IgM type, on 2 occasions at least 12 weeks apart, and anti-glycoprotein antibody on 2 occasions at least 12 weeks apart. Now the next is the cerclage. So when I talk about the cerclage, there is abdominal cerclage and vaginal cerclage. Vaginal cerclage is the most commonly that is done. It is removed at 37 weeks. Now the vaginal circulation is divided into two types, that is Shirodkar and McDonald. In the Shirodkar, muslin tape is used, while in McDonald's, bursting suture is used and a propylene suture is used. The bladder is dissected in case of Shirodkar, and it is going to be better thickness compared to McDonald's. Both these transvaginal circulation is done at the level of internal os, and the post-operative complication is going to be chorioamnionitis. In the abdominal circulation, the delivery is only by C-section, while in vaginal circulation it can be done by normal vaginal delivery as well. The abdominal circulation is removed after family completion, and it is technically difficult to perform. Examples is going to be laparoscopic cerclage. Cerclage is contraindicated if it's a case of active labor, premature rupture of membranes is present, or fetal distress anomaly is present. Worm cerclage, it is going to be emergency cerclage. Here it is a cervical dilation is seen, and the pregnant woman is less than 24 weeks. The next is going to be the MTP. So in the MTP, the first trimester abortions, they can either be done medically or surgically. So medical abortions is mifeprostone 200 mg. It is going to be anti-progesteronic receptors. Then misoprostol is PGE1. It is going to induce contractions and bleeding in about 4 to 6 hours after consuming. The dose of misoprostol is 800 micrograms through vaginal route. Contraindications: if the hemoglobin is less than 8, uncontrolled hypertension, seizures, or adrenal failure is present. Then surgical method is dilatation and evacuation. It can be performed up to 12 weeks, maximum till 14 to 16 weeks. It is done by Hegar's dilator and Karman's cannula. The number of Karman's cannula equals to the period of gestation. Maximum number can be 16 that can be used. Paracervical block is given. Uterine sound is used to measure the uterocervical length. The pressure inside is more than 600 mg for the manual vacuum aspiration of the vacuum. The most common complication is the perforation. If it is a stable patient, diagnostic laparoscopy is done. If it's unstable patient, diagnostic laparotomy is done. In rural places, manual vacuum aspiration, MBA or MR syringe can be used, and prophylactic antibiotic given, that is doxycycline oral. Now in the second trimester abortions, it can be either medical or surgical. In medical abortion, we give misoprostol 400 microgram 3 hours early. 5 doses are given on IPD basis. But in surgical, earlier it was surgical, it was suction and evacuation. In second trimester, it is dilatation and evacuation. It is done by using ovum holding forceps or sponge holding forceps, and the product of conceptus is removed, and in a blunt curettage is done. Sharp curettage is done in case of molar pregnancies. Now the different types of abortion: the height of uterus, the condition of internal loss, ultrasound findings, and management. Now the first is the threatened abortion. In threatened abortion, the height of uterus is equals to the period of gestation. The internal loss is closed, or ultrasound cardiac activity is present, and management is reassurance. It's an inevitable abortion. It's irreversible in nature. The internal loss is open. Height of uterus is equals to the period of gestation. On ultrasound, cardiac activity is absent. Management is medical, surgical abortion. Then the next is incomplete abortion. In incomplete abortion, the period of the product of conceptus, it is incompletely expelled. The height of uterus is less than the period of gestation. The internal loss is open. Ultrasound shows the incomplete product of conception, and management to maintain the vitals and abort it. Complete, here the internal loss is closed, empty uterus is seen, and the only management is here to give reassurance. The most common is the missed abortion. The missed abortion, where a brownish discharge is seen, height of uterus is less than the period of gestation, and internal loss is closed. Ultrasound, in the ultrasound, there is a mean sac diameter of more than 25 millimeters, where no fetal pore is seen, or the crown rump length is more than 75 millimeters with no cardiac activity. The management is medical and surgical. Then the next is the twin pregnancy. In the twin pregnancy, either it is dizygotic or fraternal twin, or monozygotic or identical twins. It follows a Helen's rule. Helen's rule, wherein 1:80 is twin pregnancy for triplets is 1:80 square and 1:80 cube in case of quadruplets. Superfecundation versus superfetation. Superfecundation, where the two acts of coitus happen within the same cycle, and superfetation, where the two different acts of coitus happen in two different cycles. Risk factor: geographical distribution, elderly, multipara. familial history, and in vitro fertilization, it increases the chances of monozygotic identical twins. Chorion and Andion. Chorion is the outer layer, it is formed by around 8 weeks. Then the next is the different types of the twin pregnancies, that is Didi, Modi, and Momo. So Didi, wherein the thickness of membrane in between the two embryos, it will be more than or equal to 2 millimeter. Here it is less than 2 millimeter. Here there is no membrane. Then in Modi has a deep connection, so it has deep vascular connection. Or twin transfusion syndrome chances are more here. In Momo, it has superficial vascular connections, and because of which the chances of cord entanglement are more in Momo. In Didi, two placentas are seen, while in Modi and Momo there is one placenta. In Didi, there is a twin peak sign or lambda sign that is seen at around 10 to 14 weeks, while in monochorionic pregnancy, that is a T sign that is seen. Then the ideal termination of pregnancy is done at 38, 36, and 34 weeks. So 38 in Didi, then Modi 36, and Momo 34. Now monozygotic twins, there are different types that depends upon the time of division. If it is less than 4 days, then Didi is formed. 4 to 8 days Modi, 8 to 12 days Momo, and more than 12 days, then it can be, if that is a division happens, then that leads to conjoined twins or Siamese twins. The most common being the paraphagus, where the abdomen and the pelvis are joined to each other. The least common is going to be the craniopagus, and for the management is done, that is C-section should be done at 32 to 34 weeks. Maternal complications, there are increased hemodynamic changes, increased placenta size that increases the risk of pregnancy-induced hypertension, placenta previa in mother. Acute fatty liver of pregnancy, chances increase because there are two fetuses, and polyhydramnios, PROM. Then fetal complications that can lead to intrauterine growth restrictions, preterm labor. The number of twins, the multipetal pregnancy can be turned into a twin pregnancy by giving intracardiac KCl injections to prevent any demise of a viable, a good fetus. The most common complication, then the cardiotocography is done at around 18 to 22 weeks, and target scan at about 18 to 20 weeks is done. Vanishing pregnancy, it is most commonly seen in monochorionic twins, where if one of the twins it dies. Twin transfusion syndrome, it is found in Modi. Here the deep vascular connections are seen. So in the donor, the renal blood flow, the GFR is going to decrease. Amnioticity, it is going to turn into oligohydramnios, where a single largest vertical pocket stuck sign is seen. Then in hemoglobin, here it will be having anemia, increased chances of cardiac failure, while in recipient it will be polycythemia, increased chances of congestive heart failure. The PSV is going to be more than 1.5 mom in case of donor, while in recipient it will be less than 0.8 mom. The staging, that is criteria for the twin transfusion syndrome, is Quintero staging. ECG of the recipient, it will show pulmonary atresia, hypertrophy of the, and it will lead to more of right dysfunction greater than left dysfunction because of a lot of weakness written. Then the management for less than 28 weeks, it is going to be the laser ablation of the vascular anastomosis. For more than 28 weeks, it is going to be angio reduction of the polyhydramnios, that is the recipient baby. The twin anemia polycythemia sequence, that is formed because of arteriovenous anastomosis. It's a milder variant of twin transfusion syndrome. Then the next is TRAP, that is twin reversal of arterial perfusion. Twin reversal of arterial perfusion, the TRAP, is one of the least common or rare complications, wherein there is arterial AA anastomosis is seen. Deoxygenated blood, it goes into the recipient twin, that leads to where the recipient twin has got a acardia. Now this deoxygenated blood of the healthy twin, it goes there, and because of which the limbs and all they develop. So acardia, acephalus, acardia amorphous is seen. Selective IUGR, that is in one of the twins, the fetal weight will be less than 10 percentile, and more than or equal to 25% discordance in the weight is seen. So that is seen, that is case of selective IUGR in one baby. Now talking about delivery, the most common presentation is both vertex. But if it's a case of first vertex presentation, then we can go for vaginal delivery. If it's a first vertex, second vertex, normal vaginal delivery. First vertex, second breech, then assisted vaginal delivery, and first vertex and second transverse. Then in that particular case, we can take the mother to the OT, give general anesthesia, internal portile coercion, and then it is delivered. It does not happen for more than 30 minutes in C-section. But however, if the first presenting baby is itself breech or transverse, then in that particular case, we go for C-section only. The next is going to be the gestational trophoblastic disease. So gestational trophoblastic disease, it is either caused because of molar pregnancy or it is molar pregnancy or hydatiform mole. The pathogenesis is undue proliferation of the trophoblast and leading to hydropic degeneration. It is associated with malignant potential. Clinical features, there is a bleeding per vaginum, which is the most common clinical presentation. Then early onset pregnancy-induced hypertension less than 20 weeks. Then because of the increased human chorionic gonadotrophin, that will lead to thyrotoxicosis, bilateral theca lutein cyst, which are more common in neoplasms. Then the grape-like vesicles are seen, and that will lead to pulmonary thromboembolism or breathlessness. What are the examination findings? So that here the DOE consistency is seen on per abdomen examination. Height of uterus is more than period of gestation. On ultrasound, snowstorm appearance is seen in case of complete mole. Management is suction and evacuation followed by sharp curettage. Hysterectomy can be done if it's a case of more than 40-year-old lady having a completed family. Investigation of choice for follow-up is beta HCG levels every weekly should be done. Pregnancy is contraindicated for the next 6 months, and contraceptive of choice in these ladies is OC pills and not IUCDs. Now, what is the difference between partial mole and complete mole? Partial mole is formed when two sperms are going to attach with one ovum. That will lead to 69XXY type, which is going to be the most common type. P57T2 maternal gene mutation is seen. Cystic spaces are seen in the placenta. Fetal tissues are present. While fetal tissues are complete absence is seen in complete mole. The diameter of the gestational sac is more in the transverse dimensions as compared to anterior posterior, and HCG levels are less than 1 lakh. While in complete mole there is a complete empty ovum. The duplication of the paternal side happens, that is the sperm duplication. So the most common type is 46XX. No fetal tissue is seen, no amniotic fluid, bilateral theca lutein cyst are seen. Avascular villi, it does not have any villi, and there is a risk of carcinoma more in case of complete mole as compared to partial mole. The most common gestational trophoblastic neoplasm is the invasive mole or chorioadenoma destruans. While in full-term pregnancy, the placental site trophoblastic tumor is seen. The placental site trophoblastic tumor, it is more of HPL. It secretes more of human placental lactogen as compared to human chorionic gonadotrophin, which is seen in case of invasive choriocarcinoma. Talking about the gestational trophoblastic neoplasm, the features are there is a persistent bleeding per vagina, bilateral theca lutein cyst are seen. Now, the differentiating feature is that the beta HCG even after 3 consecutive weeks, it shows a peak. So if a plateau is seen, that's a suggestion of invasive mole. But however, the beta HCG levels are increasing, then it's a suggestion of choriocarcinoma. In choriocarcinoma, there is no chorionic villi also seen. What is the most common site of metastasis? Lungs, followed by urethric nodule in the vagina, and in the lungs it forms the cannonball appearance. Then the staging is 1, 2, 3, 4, that is FIGO staging. So in the 1, it is limited to the uterus. 2, it involves the pelvic organs, and the 3, it goes into lungs or vagina, and in the 4, it goes into the brain or liver. Now this is very important, that is the WHO risk scoring, where low risk and high risk are, it is classified. Then if the age is less than 40, it's a low risk, more high risk. Interval between the pregnancy, it is less than 4 months, low risk. High risk, it is more than 12 months. If the antecedent of pregnancy is molar, then it's a low risk. But however, if the antecedent pregnancy is normal full term, then it's a case of high risk. HCG levels, if they are more than 10 to the power 5, high risk. Then size more than 5 cm, high risk, less than 3 cm, low risk. The site of metastasis, it is to the common sites like lung or vagina, then it's going to be low risk, while it is there in the brain or liver, that is going to be high risk. And previous history of failed chemotherapy, if it is present, then that is high risk. If the score comes out to be less than or equal to 6, then you have to manage it like a stage 1, and if it comes out to be more than or equal to 7, you have to manage it like the FIGO stage 4. So in the FIGO stage 1, where it is limited to the uterus, we manage it by giving methotrexate and folinic acid. In stage 2 or 3, it depends upon this low risk or high risk. If it is less than 6, then we go for methotrexate folinic acid. If it's more than 7, then multi-drug regimen, as similar to stage 4. So in the stage 4 multi-drug regimen, it consists of Backshore regime or the Emaco regime. It is resistant to that, then we go for EMAEP regime, where The EP stands for etoposide and cisplatin. The radiotherapy is given when brain metastasis is present. So this is about the molar pregnancy and the gestational trophoblastic neoplasms. After the gestational trophoblastic neoplasms, the next is ectopic pregnancy. The ectopic pregnancy is caused because this corpus luteum is present. It increases the progesterone. If it decreases, then that usually leads to shading and decidual cast. But when this corpus luteum is maintained, that will lead to increased progesterone, that will lead to decidualization of the endometrium and decidual vari is formed. The narrowest part of the fallopian tube is the intramural part, greater than the isthmus. Anatomical sphincter is present at the level of interstitium, while physiological sphincter is present at the level of isthmus. Most common site of ectopic is ampulla. The least common is going to be interstitium. Largest duration of ectopic pregnancy within the fallopian tube, it happens into the interstitium, and the smallest happens at the level of isthmus. But however, the overall longest duration of ectopic happens in the abdominal region. The most common non-tubal ectopic site is ovary, and the least common is the previous LSCS scar. So if any woman she comes complaining tenderness while in the pregnancy in the previous LSCS scar, then you have to perform an immediate C-section, otherwise uterine rupture can happen. Then tubal abortion, most common site is ampulla, and tubal rupture, most common site is isthmus. Risk factors are, most common risk factor for ectopic pregnancy is PID. Then highest risk is with a history of previous tubal ectopic, and contraceptives failure, most common tubal ligation followed by progesterone containing ICDs and followed by copper containing ICDs. Clinical features, it comes with the clinical feature of ABP, that is amenorrhea, bleeding per vaginum and pain. It's a case of unruptured ectopic. Here you will find that the gestational sac is absent, yolk sac is present. It is called as the Buggles sign or the tubal sign. So the Buggles sign or tubal sign, ring of fire sign. The ring of fire shows that vascularity is present on the periphery, empty uterus, and adnexal mass is seen on ultrasound. If any of these signs is present, we go for beta HCG. Beta HCG levels, if there are more than 2000 but still gestational sac is not seen, then it might be a case of ectopic pregnancy. If it is less than 2000 and empty uterus is present, then it might be a case of early intrauterine pregnancy, ectopic or non-viable. For that we do a beta HCG repeat. Beta HCG repeat, if it beta HCG levels increase, that's early intrauterine pregnancy. If it remains constant or if it rises mildly, then it's mostly a ectopic. If it decreases, then that's a non-viable or abortion case. The gold standard to determine the ectopic pregnancy is laparoscopy. Now if it's a case of unruptured ectopic, we manage it medically. The size, the medical management indications are the size of ectopic is less than 4 cm, HCG levels are less than 5000, and the cardiac activity is absent. In that case, we give methotrexate 1 mg per kg dose, single dose intramuscularly. Then in between day 3 to day 7, we check the beta HCG levels. If they fall more than 15%, it's good. If the fall is less than 15%, we give another methotrexate shot. This can be done for 3 times. If still the beta HCG levels are prominent, then in that particular case you have to go for surgical option. So surgery is indicated when the ectopic is less than 4 cm, but it is resistant to medical therapy, or if the ectopic is more than 5 cm. If the ectopic is more than 5 cm, we straight away go for salpingectomy. But however, if the ectopic is less than 4 cm, we go for salpingostomy. Expectorant management is done when the HCG levels are less than 200, but it plateaus over there. That's a case of ruptured ectopic. The most common site for ruptured ectopic pregnancy is going to be isthmus. So it leads to hemoperitoneum, shoulder dip pain, and the pain increases on defecation, orthostatic hypotension, shock index more than 0.85, localizing signs are present at cervical motion tenderness. If any of these signs are present, then we go for surgery, which includes the unilateral salpingectomy and cultucentesis for all the hemoperitoneum, that is the blood that is accumulated. Now heterotopic ectopic means there are two embryo, one is there in the intrauterine and other is ectopic. So in that particular case, we go for surgical management only, because we cannot administer methotrexate. Otherwise, the intrauterine normal pregnancy can vanish. Then what is angular versus corneal? Angular is the intrauterine pregnancy, while corneal is, remember, corner मध्ये असतो, म्हणून that is ectopic in nature. It is lateral to the round ligament. Then non-tubal pregnancy is very important. What is the criteria that is used? So remember PCOS in student. So cervical, it is going to be Palmer criteria. Then ovarian, it is going to be Spiegelberg criteria, and for abdominal ectopic, it is going to be Studley-Form criteria. So starting off in the next is going to be the antepartum hemorrhage. Antepartum hemorrhage is defined as a hemorrhage less than 28 weeks or less than 20 weeks of pregnancy. The most common cause is abruption of placenta. Second most common is the placenta previa. Apart from that, vasa previa, preterm labor, and uterine rupture are going to be the other different causes. Now, it is very important that the placenta previa is a contraindication for upper vaginal examination. Placenta previa, the definition of placenta previa is that this placenta lies in the lower uterine segment. Pathophysiology is the dropping down of the placenta happens. It happens because of poor decidual reaction in the upper uterine segment, or the zona pellucida does not, it fails to disappear. Now, there is a persistence of chorionic activity as well. It is seen. Diagnosis is made in the third trimester by transvaginal ultrasound. MRI is done for posterior placenta previa placenta accreta spectrum. The best time is 32 to 36 weeks of ultrasound. Classification, only classification is 1, 2, 3, 4 in the world. In the 1 there is lateral placenta previa. In the 2 there is either anterior or posterior. Posterior is the most dangerous variety. 3 is going to be incomplete placenta previa, and 4 is complete placenta previa. According to new, it is either low-lying placenta or placenta previa. Placenta previa, where it covers the internal loss, and the low-lying placenta, it is within 2 centimeters of the placenta of the internal loss. Risk factors, the most important is previous history of placenta previa, large placental size, as in diabetes mellitus, twin pregnancy, Rh negative pregnancy, and adhesion formations. Then presentation. Remember, the most common malpresentation is the transverse lie, and the most common cause of transverse lie is actually the preterm, but however, in term babies, it is placenta previa. Then placenta accreta, it is seen, and that is Stolberthy sign. It's seen on posterior placenta previa. Here, the abdominal pain is not present. The bleeding per vagina happens, and it is going to be a fresh bleed, bright red in color. Warning hemorrhage is seen. Uterus is not tender. The height of uterus is equal to the period of gestation. Fetal heart sound is normal, and it is non-tender in nature. Management: if it's a third trimester lady coming with bleeding and without abdominal pain, first resuscitate, check for vitals, check whether the DIC profile, and fetal distress. If it is abnormal in nature, then that particular case, immediate C-section is done. If all the parameters are normal, then transabdominal ultrasound followed by transvaginal ultrasound, and elective C-section is done for placenta previa at 37 weeks. If it's a upper uterine segment, then in that particular case, term delivery can be done. Now, in case of female in first or second trimester with no bleeding or no pain, but on regular checkup, if she found to be a low-lying placenta, in that particular case, you are not going to do anything. You give the basic advices like no coitus or no heavy work and all, and ask her to repeat this test at about 32 to 36 weeks. Now the next is, according to the new classification, it's a low-lying or placenta previa. It's a case of low-lying placenta. Within 1 centimeter, you have to go for C-section. 1 to 2 centimeter, you have to go for normal vaginal delivery, and for placenta previa, C-section is done. Abruption placenta, the pathophysiology is that there is a premature separation of the placenta, and it happens because of the retroplacental bleeding, and this bleeding happens because of the rupture of the blood vessels, and because of which the thromboplastin is released. The levels of thromboplastin increase and increases the chances of DIC. So most common cause of DIC is abruption placenta. After pathophysiology, there are 3 types: the concealed type, revealed type, and the third is the mixed type. Page classification, according to page classification, 0 is the retroplacenta blood flow is present. In 1, fetal heart sound is normal. 2, fetal heart distress is present, and in 3, there is a fetal demise and DIC is present. The risk factors, the most important obviously is the previous history of placenta previa, apart from the pregnancy, discharge hypertension, then pre-gravida smoking. Uterus, cubular uterus is seen. Cubular uterus is nothing but discoloration because of venous congestion that is seen in the myometrium of the uterus. It is also called as uteroplacental apoplexy. Then the clinical features of bleeding is present. Then it is going to be dark red bleeding, non-recurrent. No warning hemorrhage is seen. Uterus is tender, rigid. Height of uterus is more than the period of gestation. Fetal heart sounds are abnormal. Investigation of choice is clinical ultrasound, and the management, if the vitals are going to be unstable, DIC fetal distress is within immediate C-section. It's a case of intrauterine fetal death and the maternal vitals are unstable, you again go for immediate C-section. It's a case of intrauterine death of the fetus but the maternal vitals are stable, then vaginal delivery can be done. If it's a normal condition, that is both the maternal and fetal parameters are normal, if the pregnancy age, gestational age is less than 34 weeks, in that particular case expectant management is done and it follows the McAfee and Johnson's regime. While if it is more than 34 weeks, then induction of labor is done. The complications for eclampsia placenta are the precipitate labor. There is a short of equal placenta agrida spectrum, wherein the placenta goes inside the uterus. So there are three grades according to FIGO classification. So it is grade 1, 2, 3, that is placenta accreta, infiltrata and percreta. Accreta, it goes superficially, in the infiltrata it infiltrates the myometrium, and in percreta it is further divided into 3A, 3B, 3C. In 3A it enters the serosa, and 3B into the bladder, and 3C it enters the pelvic structures. The pathophysiology is the absence of deciduous layer and netta bush layer, as well as hyperinfluenza is seen. The most common risk factor is placenta previa, and the maximum risk it is associated when a C-section is done for a previous placenta previa. Then investigation, the maternal markers that are seen, that is serum AFP and serum HCG levels, they should be more than 2.5 mom. Screening anomaly scan. Investigation of choice is USG with Doppler at around 28 weeks, and on ultrasound they will find large placenta lacunae or lakes, and the sonolucent areas, small hidden areas are seen, thinning of endometrium. Then the bridging of vessels between the placenta and the bladder can be seen, and loss of decidua basalis. Management antenatally, elective C-section is done, followed by hysterectomy, and associated with placenta previa, classic C-section is done. For postnatal, it is intractable PH, which is then followed by hysterectomy. Then preterm labor. Preterm labor is described when the labor starts at around less than 37 weeks. The most common cause is idiopathic. The most common cause of painless preterm labor, it is going to be a spontaneous one, that is previous history of short cervix, or previous history of preterm labor. On the transvaginal ultrasound, that is done at around 16 to 24 weeks, the cervical length is found to be less than or equal to 2.5 cm. Initially the cervix is T-shaped, then the V-shaped, then the U-shaped. What is the management? Quit smoking. Progesterone is started at around 16 to 20 weeks, continuing up to 36 weeks. Cervical circulation is done at 12 to 24 weeks, and they remove the sutures at 37 weeks. And it should not be done, however, if there is a rupture of the uterus, that is prevented. Now, if there is a case of contractions, that is 4 in 20 minutes or 8 in 60 minutes, and cervical length of 2 cm, then post-cervical examination is the first to be done. Per-vaginal examination is contraindicating preterm labor and premature rupture of membranes. Along with that, we say it to be established preterm labor when the cervical dilation is more than 2 cm, cervical length is less than 2 cm, and fetal fibronectin is positive. Fetal fibronectin is positive at more than 35 weeks, but it is positive less than 35 weeks, and that is abnormal. In that particular case, you have to manage this by first giving steroids. So in all cases less than 34 weeks. If it's more than 34 weeks, you have to give steroids after ruling out chorioamnionitis. Dexamethasone is preferred. Then tocolytics are given. Less than 34 weeks, the tocolytics actually help in accentuating the steroid action. More than 34 weeks, it is of no use. Then atosiban is a tocolytic that is used in cardiac patients. However, the most common in India is the calcium channel blockers. Indomethacin also acts as a tocolytic. Remember, the magnesium sulfate is not given as a tocolytic because it has a dose-dependent action. Beta agonists like terbutaline or retrodrine are given. Magnesium sulfate only is given if it's a case of less than 32 weeks and neuroprotection is required. Screening for group B streptococcus is done from 35 to 36 weeks. So these steroids and tocolytics are the most important management for preterm labor. Now, if the pregnancy is at 36 weeks or say 35 weeks plus 5 days, then you should induce labor or allow the labor, as both the tocolytics and steroids are contraindicated after 34 weeks. Now, premature rupture of membranes. Premature rupture of membranes means more than 37 weeks, but however the Before the onset of labor, only the membranes are ruptured. The patient will come with these words, that is, the clothes are wet or excessive vaginal discharge is present. Now it is divided into two: early preterm premature rupture of membranes, or late preterm. So early PVROM is less than 34 weeks and late is 34 to 37 weeks. What are the consequences? It leads to cord prolapse, abruption of placenta, then oligohydramnios, that is decreased spondylitis, immediate delivery or precipitate labor can happen for that and then chorioamnionitis. Chorioamnionitis is the feared complication wherein the fetal heart rate is more than 160, WBC more than 15,000, polymicrobial infection it is, and the management is ampicillin gentamicin, fever more than 39 degrees Celsius or 101.4 degree Fahrenheit, uterine tenderness, out of which the fever is the most reliable sign. If it's a case of chorioamnionitis, then the only management is you have to go for induction of labor by vaginal route. C-section in this particular case in chorioamnionitis is contraindicated because it increases the chances of endometritis. However, remember in premature rupture of membranes, the per-vaginal examination is absolutely contraindicated. Kit tests can be performed like actin test or amnesia test. Actin test, it tests the placental protein 12 and amnesia for PAMG1. Then group B streptococcus screening is done at 35 to 37 weeks in all pregnant women, and if anywhere the fever is more than 100 degree Fahrenheit for more than 4 hours, then penicillin and erythromycin is given. How to differentiate whether it's amniotic fluid or vaginal discharge? So remember, the vaginal discharge is acidic in nature, amniotic fluid is alkaline. Vaginal discharge is yellowish in color, while in amniotic fluid it will show a furling pattern. Then the last topic in this obstetric complication is the postpartum pregnancy and macrosomia. The in the postpartum pregnancy, you know that the normal duration of pregnancy is 9 months plus 7 days or 40 weeks or 280 days. Normal duration of pregnancy is 37 weeks to 41 weeks. But it is more than or equal to 42 weeks, that is beyond 42 weeks, we consider it to be postpartum pregnancy. That is more than 294 days. Normal physiology is that estrogen is not secreted by the placenta. Why? Because placenta lacks 17 alpha hydroxylase enzyme. Then who produces it? The fetus. The fetal adrenals, they have the C19 steroids. They will convert it to DHEA, DHEA sulfate, that will be acted upon by the sulfatase and aromatase enzyme, that will lead to formation of estrogen. And this estrogen is the one that will lead to induction of labor, that is, it will induce the contractility. Now, these fetal adrenals are absent in case of anencephaly or fetal demise. Then similarly, C19 steroids are absent in case of Down syndrome, and placental aromatase or sulfatase deficiency can also lead to induction of labor. Consequences of this are going to be macrosomia. In macrosomia, there is a weight of more than 4 kg. Organ least affected is going to be the brain. We have to do induction of labor at around 41 weeks by vaginal delivery. And oligohydramnios is seen in postpartum is pregnancy that can lead to cord compression, and CTG showing variable deceleration. Fetal distress can also lead to meconium aspirations and proven postterms. Similarly, neuroplacental insufficiency can be seen. However, the most common fetal complication that is associated with postpartum pregnancy or macrosomia is shoulder dystocia. So, if we talk about the C-section, C-section is required if the weight of the fetus is more than 5 kg, and but however, it's the case of diabetes mother, then more than 4.5 kg weight to go for C-section. On ultrasound, we go for abdominal circumference. We find that the abdominal circumference is more than or equal to 35 cm. It is measured in the plane where the three structures are visible, and the mnemonic is pus. So, portal sinus, then umbilical vein, and the stomach of the fetus is seen and shows a hockey stick appearance. The best clinical method, however, is the Johnson formula, wherein the fundus height in centimeter minus 12 multiplied by 155, it gives us the approximate weight of the fetus in grams. Amniotic fluid index, we say olive hydramnios, it's seen in postpartum pregnancy, IUGR, that is seen in premature rupture of membrane, UPI, renal genesis, where less than 5 centimeters the amniotic fluid index. If it is more than 25 centimeters, then that is the polyhydramnios, which is seen in case of anencephaly. Fetal anomalies like spina bifida or anything, diabetes, multiple gestation. Bishop score is used to find where induction of labor is required or not. If it is less than or equal to 5, then the cervix is not ripened where induction of labor is required. If it is more than 8, then it's already a favorable cervix. It can directly lead to spontaneous labor. So these are all the obstetric complications in pregnancy.